All right, so I will start my presentation now, and thank you for the warm introduction that you gave me, sir. Having said that, all I can say is, hi, I'm Natalie, and I'm the person standing between you and your lunch out there, so trust me, I will make this quick and worth your while. So as you can see, the goal of this work was to identify safety signals in social media and in the World Health Organization data and compare them and see how they compare. And what we did was work together with Sanofi Pharmacovigilance department so that we can develop processes that eventually will be implemented in routine pharmacovigilance. So let's dive into our presentation and some core terminology. As we all know, post-marketing safety monitoring relies on patient feedback largely. And patient feedback is something that is shared between patients and their other peer patients and caregivers. We all call this thing the patient voice. And contrary to what we may all think, this thing does not disappear into thin air. It's actually very well documented out there in patient forums and communities. The information is stored out there, but it's not properly tapped into by the pharma companies or the regulators for that matter. Now, a subset of the patient feedback is called the patient complaints, and that is also shared between patients to physicians and other healthcare practitioners. And sometimes the patients complain to the manufacturers about the products. But in general, a large portion of that is also not reported, and only a subset of the complaints are eventually reported as adverse events, and they are processed, and then some regulatory action is triggered. Again, the adverse event is usually something that was reported to the regulator. Now, if we look at this pyramid and we ask ourselves, what is wrong with that pyramid? The answer is pretty trivial. The problem is that there's a lot of information created out there, but what is processed is only what is registered by the regulatory bodies. So only the adverse events are processed, and the rest of the information is left out there in social media or in the EHR systems, and it's not tapped into, and this is how we have such a high underreporting, and this is how we have so many adverse reactions that can be prevented, but they are not prevented, and that's a shame. So this is what we had once we were entering this project with Sanofi Pharmacovigilance department. We were thinking, how can we tap into the patient voice? And most importantly, how do we create processes that allow that process to be repeated once and again and again and again? Because the idea was to create routine processes, not something to work our way to find certain adverse events on social media once or twice. We wanted to have methods to harvest, process, analyze, and most importantly, interpret the social media, because it really is a different data source. You have to know how to work with it, and we set out to develop those methods to work with social media. This is a slide that summarizes the project that we have performed. I know it's a very busy slide and a scary one, but bear with me. We will refer to each and every point in this slide. So the process was as follows. Initially, we identified adverse events in the VigiBase. We took two very well-known and very much used drugs, zolpidem and insulin glargine, and we extracted all of the adverse events from VigiBase for the 2005 until 2015 period of the study. So that was a lot of information, and as you know, VigiBase is a very large data set. It has millions and millions of adverse events. And then we went on to extract that information from the social media, and this is where the things get complex. Because in social media, you don't just extract adverse events, you actually have to process the texts that are in the patient posts to identify the adverse events. So we used two separate methods to identify adverse events in the patient texts. So first of all, as you understand, we downloaded the posts, we cleansed them, we got rid of the personal identifiers, and then we had to identify the adverse event text, and we used two separate methods. Method number one is called the co-occurrence method. It is a very simple method, and as the name implies, it basically identifies all posts where a drug and any clinical event are mentioned together. It's trivial, it's very simple, and it's not even adverse events per se, it's potential adverse events. So if you have posts saying that I feel nauseous and I am using insulin, that's not necessarily an adverse event, but co-occurrence will fish that post out for you. And on the other side of the slide, you can see the second method, which is called the natural language processing method, the NLP. And that method does identify a language that patients use when they describe an adverse event. I took insulin and I felt nauseous. So that is a potential adverse event. And what co-occurrence identifies is much more crude, much more rough. And we used both of these methods and ran them in separate, but in parallel. And so from once we have identified the adverse events in social media, we then went to the phase 3, where we identified the signals. Anyone who ever worked in signal detection identifies the algorithms, PRR, ROR, and so on and so forth. Now, on to some numbers. So we have extracted the posts, and as you can see, there were a lot of posts. 700 million posts is a large number of posts. And I forgot to mention only for these two drugs. I forgot to mention in the previous slide that we crawled over 1,000 patient forums and communities. So that there was a lot of material for those 10 years for only these two drugs. Thank you for your comment. From that number, we boiled it down to only posts that were mentioning any medical concept, so sign, symptom, or a drug. And that was a much lower number, but still a vast number of posts. And this was our 100% post population. From there, we went on to posts mentioning the study drugs and medical events. I remind you that method is called the co-occurrence. And as you can see, the numbers are really smaller. They're much more manageable than what you could think among the million posts that we have downloaded. And the next step was identifying, using the NLP algorithms, identifying the potential personalized adverse events. So 435 adverse events were identified using the NLP method. And from both these levels, we then identified potential signals. So the first thing that we have seen in our project is that even when you work with thousands of patient communities and millions of patient posts, eventually you do go down to manageable numbers of adverse events, and that is something that is definitely can be streamed to routine pharmacovigilance processes. And the next idea was to identify how the social media adverse events intersect with the VigiBase adverse events. So we took the 2,500 co-occurrence potential adverse events, and we compared them with the VigiBase adverse events, and this is where it got interested. Actually, 57% of them were already present in the VigiBase, so that concordance to us was very high. And then we did the same comparison for the NLP potential adverse events, and the concordance went even higher. And that means that, first of all, the notion that social media is bogus and there is nothing out there, it's all hypochondriac patients, is not correct. The adverse events you find in social media are also the ones reported to the regulators. So something to pay attention to. The next step was to compare the signals that we identified in the co-occurrence and the NLP. And we saw that 37% of them were identified also in the VigiBase, and the NLP SDRs were up to 60% also identified in the VigiBase, depending on the signal detection method that we were using. And this is where you're supposed to ask me a very valid and legitimate question. If you have 60% of the signals in the VigiBase, why do you even need to go through the trouble of streaming social media in your routine pharmacovigilance? Now, the answer to that, to me, is straightforward. First of all, if 60% is concordant, who is to say that the other 40% are useless? You at the very least, have to go and check them, address them, and see whether some action needs to be triggered. And the second answer to that question is that we checked the timing of social media signal detection, and we saw that it was earlier than in the VigiBase. So among the common signals we identified in the VigiBase and the co-occurrence, we saw that up to half of them were identified earlier when we were using the very simple method of co-occurrence, and up to a third of them were identified earlier in the NLP signals. And when I say earlier, I mean at least 1 month earlier. So that's a significant time reduction. So there were a lot of findings in that process, and we have a lot of aha moments in that project together with our Sanofi colleagues. But we picked for this specific presentation, we picked 5 major points that we wanted to bring for you today here. So the first idea that we are putting forward is that even when you're crawling over 1,000 patient communities, you still have a manageable number of adverse events, and you can work with that in your routine practice. Point number 2 is that social media adverse events are very consistent with regulatory adverse events, so you have to consider that data source as a valid one, or at least something that complements your routine practices. Point number 3 is that signal detection works with various levels of text processing. You don't even have to go very fancy. You can work with a method as simple as co-occurrence. It's even considered a very trivial method, but you have seen that results show that it also brings value to your processes. So it's up to you to decide which method you're using, but any one will work. Next point is that social media signals can be identified earlier than the regulatory signals, and you have seen that co-occurrence raises up to 50% of the detection to a 1 month earlier point. With the NLP, the results are lower, but still very good. 30% detection, early detection, is something that we really strive to. And in terms of the signal detection methods, we have seen that there is a range of performance of Bayesian and frequentist signal detection methods. And again, you can choose any one that works best for your tools, but you have to adjust them to your internal practices. And the take-home messages, as I promised, we're good on time, and even have some time for questions. So no one argues that social media is a problematic data set. It's vast, unstructured, it's chaotic, basically. But we have been able to identify some important components in social media processing, and this is what we offer to you today. So point number 1, focus on medically relevant forums. That may sound trivial, but really crawling through forums which deal with dating and music sharing and movie sharing, that may occasionally raise some medical information, but really it is so rare that it's not worth the while. Point number 2, use appropriate language processing methods. Again, you don't have to be very fancy with your language processing, but do choose the one that works best in your department and stick to it. Point number 3 is use patient healthcare vocabularies. As we all know, patients don't use proper clinical terminology, and this is why you have these vocabularies. We in Data to Life have our own proprietary patient healthcare vocabularies. You can download yours from the online tools from different academic sources. And the last point is that when you process social media, always cross-reference with traditional data sources, not just to validate the results, but mostly because traditional data sources bring to you signals that are more clinically severe, clinically serious, and the social media reflects better the quality of life of the patient and the patient-centric insights. And when you put them together, you basically have your complete and comprehensive picture.